So, dear colleagues, hello, hello. We hope many of you had already your annual leaves, or at least planning them soon. Meanwhile, we continue a series of webinars devoted to different aspects of MHPSS during COVID pandemic. We all know from our past experience in Eastern Ukraine that serving vulnerable groups and people with disability is not easy, always not easy, but today it becomes even more challenging since we have many new restrictive measures and other barriers. So today we have a fourth workshop from a series which is specifically devoted to vulnerable groups and people with disability and their specific considerations for providing services and organizing services for them during COVID pandemic. Today we have a pleasure to introduce to you Dr. Anita Marini, who is a global MHPSS expert and executive psychologist within the Italian public health system and international mental health consultant with particular expertise related with people with disability and vulnerable groups, and huge experience in working with those groups. So Anita, please, over to you.
Thank you so much. It's a pleasure for me to be with you, although at distance, unfortunately, as everything is nowadays. And for me, it's particularly different to be after a screen because I'm Italian. So I speak by hands, and now you cannot see my hands. I hope that I will make it anyway. So it's really a pleasure to share some work with you and all the participants of the working group. If it is possible and we have time, I would like to hear a very short presentation from the group participants, like the background and the organization they are working with. I'm a psychologist by background, and I've been working mainly in emergency settings, but also in developmental settings as a public mental health, let's say, technical officer. So if I can hear very quickly from the participants, just like a quick introduction to see each other, then we will have later more room for discussion. Thank you so much.
Sure, I can start since I already Galava. I'm from WHO. I'm a mental health officer in WHO. My background is I'm a psychiatrist and with experience in outpatient and inpatient mental health care system, and now with public health experience with WHO, covering humanitarian and development areas of work with regards to mental health, of course. Thanks.
Okay.
Oksana, probably over to you.
Thank you. Hi, everyone. My name is Oksana, and I am Coordination Support Consultant of Mental Health and Psychosocial Support Technical Working Group for Ukraine. I have a background in project management and humanitarian response. Thank you.
Good afternoon. Elena Sokolova, project expert from the HelpAge International Project. I work with Severodonetsk town, represent Lugansk region. I work in 2 projects with the support of Ukrainian Humanitarian Foundation, and I held control over the projects related to psychosocial support to elderly. It's 5-kilometer zone at the line of, so to say. So we cover in Lugansk region Popasnya district, Novoaidar district, partially other districts. If you have any questions, please. Thank you.
My name is Anna, and I work as a mental health and psychosocial support coordinator with the organization MDM. It's a Medicus del Mundo mission in Ukraine. And I have a number of colleagues with me now also, now connecting from Stanitsa Lugansk field visit. And it's great to see you and happy to meet you via the screen, Anita.
Good afternoon. My name is Inna. It's a very great distortion in the medical practitioners of the world. Good afternoon, ladies and gentlemen. My name is Lyudmila Kameneva, psychologist, work at MDM company. We work at Stanitsa Luganska and the Americans in line. And good afternoon, dear colleagues. My name is Natalia Shevkun. I work for Doctors of the World, and I am a program manager in mental health. My major place of work is in Severodonetsk town.
My name is Susanna. I'm a health project manager with PUI. Happy to start working with everyone. Look forward to the information in this workshop. And I'll pass the floor to my colleagues, Valeria and Olga.
Good afternoon. Name's Olga. I believe that you hear me clearly. I'm a psychologist, Premier Jones organization. This is my organization. We are involved in psychosocial support of Donetsk region population. We are based in Konstantinovka town. I'm happy to welcome everybody, and I wish we'll have a fruitful work today. Thank you. I am a psychologist, Valeria Volkova. We started working in Novobreak this year. We are the first rank psychological support. We are running our rating, continue our program in NHP. And now we continue with the groups, and we are involved in supervision as well. So welcome everybody, and I wait for new information from you. Thank you.
Okay, so it seems that we've done with intro, and Anita, over to you.
Thank you so much, and thank you for the patience required for a virtual introduction. Thank you so much. So today I will share with you some experience in the MHPSS response inclusive of people with disabilities in emergency settings, and particularly during the COVID. So the outline of the presentation will be the impact of COVID-19 on the mental health and psychosocial well-being of the population. Then we are going to address the vulnerable groups as a target population. Among the vulnerable groups, particularly persons with disabilities, and the barriers and risks faced by persons with disabilities in emergency settings, and particularly during COVID-19. And then what we can do as MHPSS professionals, or in our MHPSS response or component of our programs. So I will not spend time in describing the COVID-19 pandemic, because unfortunately I think that all of us are hearing enough about this new emergency. I want just to highlight that it's a different emergency from the ones we are used to, also like working at the global level or in international cooperation. It's different because actually it's global. So we are used to think of emergency settings which are regionally, like geographically defined. So there could be a war in some countries or a natural disaster in some countries, while this time all the countries in the world at different intensity are affected from this emergency. There is a very high impact of of the COVID-19 at different levels, which means like, of course, at the health level, but also at the social level, especially due to the restriction measures applied, and also at the economic level, which is then a determinant of health, a very important social determinant of health. And what about the impact on mental health and psychosocial well-being? So the Interagency Standing Committee Reference Group for Mental Health and Psychosocial Support in Emergency Settings has identified like some main, let's say, elements of the impact. So people all over the world are facing severe impacts on their mental health and psychosocial well-being. And for example, in my region, we have been conducting an assessment of the MHPSS, say mental health and psychosocial well-being of the general population, and we are analyzing these days the preliminary data. We have administered a structured interview and also standardized and validated psychological screening tools, and we are seeing in 600 persons, I mean, it has been administered to 600 persons, and we are seeing that so far 85% of the population has a medium and high level of distress due to the COVID and the restriction measures. So psychological distress is widespread in the entire population due to the effect of the virus on health, but also on the measures that are applied to contain the spread. Therefore, like this physical isolation, also the interruption of many basic services, and also more and more the worries and the anxiety related to loss of livelihoods, of work, of jobs, and also loss of education for children and youth. Furthermore, the direct effects of the pandemic are compounded by the effect of other humanitarian emergency that are going on in many countries. So today we are going to talk about the vulnerable groups. Who are the vulnerable groups? We are currently trying to redefine vulnerable groups and to talk about persons who face higher and multiple protection risks in a given context. It's not just a terminology, it is to shift the attention toward the context where a person lives, which can reduce protection risks or otherwise augment and exacerbate protection risks. So when we talk about vulnerable groups, it's something that could be wrongly immediately attributed to the persons. While talking about risks or protection risks, we are focusing more in the context. So who are the vulnerable groups in emergency settings? And even more specifically during the current pandemic. For sure, persons with disabilities, because they are more at risk also from an health point of view for pre-existing conditions. Persons with invisible disabilities, which means persons with psychosocial disabilities, with intellectual disabilities, and with cognitive disabilities. We will come back later very quickly on the definitions of these different types of disability. Children, girls and women, and particularly pregnant women, elders, especially during COVID-19, because they are most at risk, and also LGBTQ. Another specific group at higher risk during COVID-19 is definitely represented by persons who lost relatives or loved ones due to COVID-19. So during our webinar, we will focus, all these we have listed, they are persons or groups who face higher protection risks or multiple risks. But during our webinar, we will focus particularly on vulnerable group of persons with disabilities. So when we talk about disability, there are different models we could refer to, but let's say that with the international framework that since 2006 have been established to enhance the inclusion of persons with disabilities, we will refer to the social and human rights framework, or the social and human rights models, defined particularly from the Convention for the Right of Persons with Disability, the CRPD. So in Article 1, we find these definitions. Persons with disabilities are those who have long-term physical, mental, intellectual, or sensory impairment, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. So here there are very important concepts to work in the disability field. And there are important concepts to work addressing the needs of persons with disabilities on an equal basis with others. So it says that the disability is the result from an interaction between impairment and and barriers. So it's not only the impairment of the persons, but it is as much also the presence of barriers in the context where persons live. And now we will see which barriers people with disability face to participation and to access to services. I want to spend one more second on mental disability. So the definition of the CRPD defines long-term physical, mental, intellectual, or sensory impairment. It doesn't talk about psychosocial disabilities. So working in collaboration with disability experts and also organization of persons with disabilities in the past 2 years, we have let's say agreed on a definition of psychosocial disability. Let me, 1 second, I misplaced, no, I didn't put it here. Anyway, for psychosocial disabilities, we mean those persons who have a mental health condition, which can be also temporary, not necessarily long-term, but also temporary but recurrent, which in interaction with barriers hinder the participation in society on an equal basis with others. So for psychosocial disabilities, we mean persons with mental health condition, long-term mental health condition, or temporary and recurrent mental health conditions. So example of barriers. So we just said that the disability is the result of the interaction between the impairment and barriers in the context. So which are the barriers faced by persons with impairments living in emergency settings? And then we will see specifically also for COVID. So first of all, there are like the pre-existing negative, discriminatory, and sometimes so overtly hostile societal attitudes towards persons with disability. In emergency settings, they are even exacerbated. And then misconception, prejudices, and stigmatizing belief also among us, like among humanitarian workers, among policymakers, health professionals. For example, the idea, the wrong idea, the erroneous idea that persons with psychosocial disabilities are dangerous, or they are unable to make decisions, or they are unable to contribute to the emergency response. This is particularly true for persons with psychosocial disabilities, but it includes also persons with physically and sensory disability. Another important barrier is that the accessibility of services is diminished due to damage or destruction of the infrastructures in conflicts, for example, or natural disasters, and during COVID, for example, due to the distancing measures. And often there is also the reduced ability of services to function because the staff can be themselves affected by the emergency. And again, this is particularly true during COVID-19. In the hospitals where I work in my region, sometimes entire wards were closed because the staff was completely affected by COVID, like all of them. Insufficient capacity of humanitarian staff to adapt information, communication, infrastructures, and service delivery to the requirement of persons with disabilities. And also exacerbated pre-existing and contextual restrictions in being able to exercise legal capacity or make decisions about all aspects of life, including about medical treatment. Very often people or persons with any kind of disabilities, they cannot exercise their legal capacity. And sometimes this is like by law, by legislation of the country. Another very, very severe barrier is being constrained. Being constrained, like because of forced institutionalization, or forced medical treatment, or even physical and chemical restraints, which of course, in addition to violates heavily human rights of the persons, it also prevents any form of participation in society and also access to the humanitarian aid. There are also limited opportunities for persons with psychosocial, cognitive, and intellectual disabilities to participate in or lead the research, and any way to influence the research agendas. So we already went through the psychosocial disability definition. Then example of additional barriers, like specific to COVID-19, faced by persons with disabilities. Of course, more difficulty exercising preventative measures because information and communication are not always accessible. We will come back later to this point, which is very important about communication and information in different languages. It often happens also that access to healthcare is deprioritized for persons with disabilities because of negative perception about their value to society. So they are discriminated by their disability. Also discriminatory criteria in decision-making processes regarding healthcare rationing, not based on individual prognosis, but assumption about quality or value of life. Again, when difficult decisions have to be made in rationing resources in healthcare, so very often these decisions are made on the basis of the disability and the assumption about quality or value of life of persons with disabilities. Then the use of technology, the massive use of technology during this pandemic for remote service delivery. And I mean, thanks God that we are able to deliver services like remotely, but this kind of service delivery online, including online MHPSS, may not be accessible to persons with disabilities, especially in humanitarian settings where access to technology is already more limited. But not only in humanitarian settings, also in regular settings, let's say. For example, in Italy, we see that the service delivery, the remote service delivery, very rarely is inclusive of persons with disabilities. Same applies to distance or remote learning and return to school programs. They are not always inclusive again of and accessible for children with disabilities, and specifically believe that persons cannot contribute, persons with disabilities cannot contribute to the response to COVID-19. And also, I mean, in the reorganization of the health services, some pre-existing services dedicated to persons with disabilities have been deprioritized to reallocate those resources towards the COVID-19 response. So these barriers are, let's say, determining higher and multiple risks faced by persons with disabilities in emergency settings in general, but also specifically during COVID. So which are the risks, the health and protections risks faced by persons with disabilities in emergency settings? They are most at risk of being left behind and marginalized. Then I will provide you with the sources of and the references and the bibliography. They are most at risk of violence, of coercion, abuse, and other violation. And then the rate of premature mortality is higher than that of persons without disabilities. Girls and young women with disabilities face up to 10 times, it's so much more gender-based violence than those without disabilities. And these girls and women are also most at risk of marginalization, exclusion, and discrimination. And children, youth, elders with disabilities are more subjected to abandonment, neglect, abuse, and exploitation. And then specifically persons with invisible disabilities, such as we said before, intellectual, cognitive, and psychosocial disabilities, and also persons living in residential institutions that could be like nursing homes or psychiatric hospitals, but also like residential institution at the Ministry of Social Development, are at increased risk of being left behind during the emergency, of discrimination, of violence, of persistent violation of human rights, of under-identification, and being excluded. And furthermore, disability-related services and supports, and also the organization of persons with disability themselves, target more often and mainly persons with physical and sensorial disabilities. I mean, also within the disability programming, often the psychosocial, intellectual, and cognitive disabilities are overlooked, also within disability programming. Then the higher risks faced, particularly during COVID or any pandemic, let's say, there is a heightened exposure to health problems because very often persons with disabilities have other, let's say, pre-existing health conditions. Late detection of the health problems, and once they've been detected, then there is anyway a limited access to treatment and care that very often is not inclusive of persons with disability. In pandemic, also violence, exploitation, and abuse are exacerbated at the household because family that could be not protective are separated from like the usual community support networks and for sure under increased stress, but also in the residential settings, in the institution, because here there is a further isolation from the protected families and the other like community networks due and prescribed by the distancing measures. Finally, also children and adults with intellectual, cognitive, and psychosocial disabilities, they may become particularly distressed due to changing routines, due also to change of the caregiver when the caregiver is quarantined or affected by COVID. Then within the persons with disabilities, there are like subgroups who are even at higher risk due to the intersectionality. So persons with disabilities are a diverse group, varying in age, gender, ethnicity, type, and severity of impairment, the barriers faced, and also the settings of living. And as in the case with anyone, all these factors together, they determine how persons with disabilities are affected by emergency, including in the way that their well-being, their mental health and psychosocial well-being is impacted. And the type of emergency can aggravate further the risks faced by persons with disabilities. For example, the social distancing, as we already said, and the massive use of technology in service delivery. So the intersectionality based on disability, age, gender, ethnicity, class, sexuality, type of emergency, compounds the risks faced by persons and their impact, as for a synergistically negative effect. So among persons with disabilities, there are groups that face higher risks. For example, like a person with, like a girl with disability will face higher risk because she has an impairment, a disability, but she is also a female. The same applies to children or elders or persons with invisible disabilities or those living in residential settings. The long-stay residential settings requires particular attention because in most of the low and middle income countries, but not only actually, standalone psychiatric hospitals and long-stay institutions are very common. And we all know that in these settings, human rights violations are very extreme. And we can say daily, very recurrent. And we all know that in this institution, the care delivered cannot be inadequate, cannot be, adequate, and cannot be quality care. And during the emergencies, especially during pandemic, this long stay institution and hospital becomes even more dangerous and life-threatening because the violation of human rights are exacerbated and any kind of protection and health risks are heightened, and abandonment is likely to happen. Actually, I mean, I've been working in several countries and regions of the world, and unfortunately, still being in contact with them, I heard of a lot of situation where COVID outbreaks happen within these institutions. But also, for example, in Italy, we had, you may already heard from the media how many elders died in the nursing homes. It was and it is very challenging, especially for those nursing homes where there are old persons with cognitive disabilities like dementia. But we will come back to it later at the end of the presentation that could be part of the discussion. So the emergency could provide an opportunity to start the reform process, the institutionalizations in those countries where the MHPSS systems are still very much based on standalone psychiatric hospital and residential institution. But nevertheless, when an emergency occurs or a pandemic, if in the country there are still residential institution or long-stay standalone hospitals, it is like extremely important, essential that we develop plans to ensure that persons living inside are not left behind and are not neglected also from the humanitarian response or from the pandemic response. So what we can do as mental health, let's say MHPSS organizations, or even if we are not MHPSS organization, but we provide some MHPSS services, or we have some MHPSS programs, what we can do. I would like to shortly define the challenges of having an MHPSS response inclusive of persons with disabilities. Globally, there is insufficient inclusion of persons with disabilities in humanitarian MHPSS responses. Also, the guidelines that are available, like the very, let's say, those guidelines which during the last decades have become very popular, very well known, which are evidence-based and adopted all over the world, they are not so much inclusive of persons with disabilities. And this is particularly true where pre-existing mental health systems are inadequate, as I was saying 1 minute ago. In those countries where the MHPSS system is still based on, central, let's say hospital-based, where there are no community-based services, where there is no the recovery and human rights model adopted, and also where there are limited resources for the training of the staff on disability inclusion, and also where there are discriminatory attitudes among the staff towards people with disability. There is also a lack of guidance on how MHPSS programs can be made more inclusive of persons with disabilities, and sometimes this translates also into unintentional, harmful, let's say, pattern by the aid actors themselves, ourselves actually. And last but not the least, MHPSS, the other way around, MHPSS is rarely integrated and considered within the disability programming. And also within now, in the last years, a lot of guidelines were published, issued on, let's say, the humanitarian response in general, like inclusive of persons with disabilities. But also in these guidelines, let's say that the MHPSS component is not so frequently included, and also persons with invisible disabilities like psychosocial, intellectual, and cognitive disabilities are not very much included in the general disability programming. So what we can do as MHPSS actors, so we can try to develop an MHPSS response that is more inclusive of persons with disabilities, along with the adaptation of the MHPSS response to COVID-19 pandemic. So there are plenty, and for me, too many, like overwhelming documents and guidelines issued in these last months on the adaptation of the MHPSS response to COVID-19. So I think there is no need for me to talk about it, and I think that you already heard by the in the previous webinars about it. So it's very important that the MHPSS response is adapted to respond to COVID-19, but also that these adaptations are inclusive of persons with disabilities. How we can do it? There are mainly two strategies that need to be combined to address the MHPSS needs of persons with disabilities during COVID-19 on an equal basis with others, with persons without disabilities. First strategy is mainstreaming disability within the MHPSS planning, programming, and budgeting, so that we can remove barriers to participation of persons with disabilities to the MHPSS response. And we can support their access to the MHPSS response on an equal basis with others. And the second strategy is designing and implementing disability-focused actions as part of the MHPSS response, so that we can ensure that the specific and individual disability-related needs of persons are met. So this is called the twin track approach. So from a side, we make all our programs and the services accessible to persons with disabilities, which is not always the case. I mean, if I think when I was working in the field, there were so many, for example, PSS activities for children that could not be accessed by children with disabilities, with physical disabilities or with intellectual, cognitive disabilities. So we need to retrofit our MHPSS programs to be inclusive of persons with disabilities. This is first strategy. And this has to be combined with not the adaptation of our MHPSS programs, but with the development of specific MHPSS activities, programs, intervention to address the particular need of persons with disabilities. So from a side, we make our program inclusive of persons with disability. From the other side, we develop new programs or new activities targeting persons with disability who have like specific needs that cannot be met in the regular programs. It is also very important to advocate, like through, for example, coordination mechanism, that psychosocial, cognitive, and intellectual disabilities, and also MHPSS considerations, are not overlooked within the disability project, programs, and the response. So the CRPD, the Convention for the Rights of Persons with Disabilities, defines also the measures that can be used to apply the twin track approach. So the measures that can be used to mainstream disability in the humanitarian programs, but also to respond to the specific needs of persons with disabilities. So the measures for inclusion which are complementary are universal design, which means, according to the CRPD, the design of products, environments, buildings, facilities, but also of programs and services, so not only infrastructures, to be usable by all people to the greatest extent possible without the need for adaptation or specialized design. And this is something that will benefit the entire population. For example, the ramp at the entrance or the automatic doors, this is something that is, let's say, benefited by all persons and also respond to the requirement of persons with disabilities. Then we have a reasonable accommodation, which is the second and complementary mean, which it is about like individual solution. So the universal design will allow for the mainstreaming of disability in our programs, and it's a general solution for everybody, while a reasonable accommodation is like an individual solution or a solution for a small group of persons with specific needs, and it's like entails modification and adjustments in particular cases to ensure that to persons with disabilities the enjoyment or exercise on an equal basis with others of all human rights and fundamental freedoms. So, for example, could be providing sign language interpreters or to, for example, a person who is who is deaf, or closed captioning at meeting and events. So from the side, we have universal design for everybody, and then reasonable accommodation to respond to the specific needs of a person. So the key action of an MHPSS response inclusive of persons with disabilities are defined by a specific, let's say, by a subgroup of the ISC MHPSS reference group. And we are working on it since 1 year, and a specific guidance will be issued hopefully soon. So first of all, the consultation with the Organization of Persons with Disability, with self-advocates and persons with disabilities as partners and agents of change in the MHPSS response. It could be useful to set up or establish like an advisory committee or a group of organization of persons with disabilities to so that we can consult on a regular basis with this group, and recommending that the disability diversity is represented within the group, because we know that the barrier faced by a person with psychosocial disabilities are different from those faced by one person, like a person with a physical disability. So it is important that the group or the committee or the board that could be established represents the disability diversity. And they are consulted, they should be consulted at the all levels of the MHPSS response, starting from the assessments, so MHPSS needs assessment, but also assessment of the capacity building needs, assessment of the barriers faced by persons with disabilities, also identification of the universal design and the reasonable accommodation measures to be inclusive of persons with disabilities. So in the conceptualization, but also in the implementation of all different kinds of assessments, organization of persons with disabilities should be consulted. Another key action would be the recruitment of persons with disabilities within our organization, or at least, let's say, avail employment opportunities which are equal for persons with disability. Safety and universal design should become a part of our regular programming, and therefore thinking of all the facilities where MHPSS is delivered, starting from the community level to the primary health care, to the more specialized care, like all the facilities used from the community to the healthcare or social settings should apply safety and universal design futures, as much as reasonable accommodations. We should ensure that assistive devices are available for persons with disabilities, which does not mean that necessarily, I mean, that our organization should provide assistive devices, but it is something that needs to be assessed if the person with disability has the necessary device for an equal participation. And if not, we can advocate and we can link with organization for the provision of assistive devices. And then capacity building. Capacity building means capacity building of organization of persons with disabilities and self-advocates, but also capacity building of family members and caregivers, and the capacity building of us, like of humanitarian workers. Capacity building on what? When we are talking about capacity building of humanitarian actors, definitely the capacity building should include the disability models, like the human rights and social model of disability, and also the twin track approach, the identification of and the definition of universal design measures and reasonable accommodation, the adaptation of the MHPSS response to be inclusive of persons with disabilities. While when it comes to the organization of persons with disability, capacity building should be, for example, about the humanitarian aid, because organization of persons with disabilities at the local or national level might not be familiar with the humanitarian response and the concepts of the humanitarian response and the possibility of participate to the humanitarian response. And then also human rights of persons with disabilities, both for self-advocates and also family members. And one point on capacity building, it is very effective to design the, let's say, capacity building events or initiatives or activities together with OPDs and self-advocates, but also to deliver them jointly. Could be time consuming, but it is definitely much more effective. And then this is, as I was mentioning before, this is an extremely important key action. So communication and resources must be available in multiple and accessible format. Multiple format means written, oral, and also pictorial format, while accessible ones mean like Braille and large print, or accessible web content by screen reader, for example, including image description or easy to read version, or plain text accompanied by pictures or sign language video. And for the communication, to use also the most appropriate channels that, depending on the context, can be radio or SMS or emails or TV, etc. And these are all recommendation included also in the CRPD, in the Convention of the Right of Persons with Disabilities, Article 3. I mean, already implementing this key action, we make our MHPSS response for sure more inclusive of persons with disabilities. Sometimes in the MHPSS services across the layers of the ISCS pyramid, across the sectors, there are no multiple format and languages used, and therefore these services cannot be accessed for persons with disability who needs this format to understand and to participate. And even during pandemic, at least in Italy, but I think this was the case in many countries, that also the information provided, like the daily updated on the pandemic, were not provided in an inclusive way, which means that they were not provided with multiple and accessible formats. So persons with disability will have to rely on caregivers or support person that they might disappear because of the emergency, and they should immediately, I mean, they will have to trust persons who they don't know, who they are new to them, even in relations to the emergency update. Another key action for an MHPSS response inclusive of persons with disability is the setup of an interagency and intersectoral MHPSS referral mechanism, which is inclusive of persons with disability. Again, one person with disability should be, let's say, referred to all the services required, providing the accessibility of these services. Service organization should be retrofit and adapted, and I think you had already webinars on the adaptation of the MHPSS services to COVID-19. But in this adaptation, we need to pay extra attention to the inclusion of persons with disabilities, and therefore use universal design and reasonable accommodation measures. Rehabilitation opportunities should be available for persons with disability even during the pandemic. And also MHPSS support for family member and caregiver, because this will enhance their well-being, will strengthen their coping skills, and support them in building a resilient environment and promoting the autonomy of persons, of their family member with disability. Then also focused MHPSS support targeting disability diversity. For example, specific psychological intervention for persons who are deaf. It is not only about the language, it is about providing support to a person who could have, due to the deafness, different kind of patterns to be addressed. Or for example, a child who is blind or who has physical mobility. Then the adaptation of those PSS programs who are already in place and who are evidence-based and very effective. So these PSS programs, for example, also the psychosocial support at school about emotional learning and so on, these should be adapted to be inclusive of children with disability. We should provide also with feedback and complaint mechanism that again are accessible and inclusive, having in mind universal design, always reasonable accommodation measures. For example, could be a web form, or could be like a hard templates in different languages, and they should be also safe mechanism, like for example allowing for anonymity. Another very important key action is about awareness campaign that should be carried out together and jointly with the organization of persons with disabilities and also persons with disability, to combat the stigma associated to persons with disabilities, to combat the discrimination, and to raise, to increase literacy about the rights and the needs of persons with disability. Then there is so all these actions will improve the MHPSS response, will make it more effective for everybody, but especially this action will make the MHPSS response inclusive of persons with disabilities. Of course, these are actions that can be broken down in very like operational instructions, and we are working on it because there is like a lack of this kind of guidance at the global level. There is a special, let's say, organization on disability, which is the International Disability Alliance, IDA, which is composed from OPDs, from Organization of Persons with Disabilities. It is like a federation of organization of persons with disabilities, and they have developed like a recommendation related to inclusion of persons with disability in the COVID-19 response. There are a lot of organizations that, of course, are issuing or are providing recommendation for the inclusion of persons with disability in the COVID-19 response. I picked this organization because it represents directly the voice of persons with disabilities. So they say persons with disabilities must receive information about infection, mitigating tips, public restriction plans, and the service offered in a diversity of accessible format with use of accessible technologies. So it is about what I was mentioning before. Communications should be provided in multiple formats, both at the, let's say, media level, but also within the services. And additional protective measures must be taken for people with certain types of impairment, especially psychosocial, intellectual, and cognitive impairment. And the response plans should be inclusive and accessible specifically to women with disabilities, which are discriminated, let's say, twice because of the intersectionality. So they are discriminated because they are women, and they are discriminated because they have a disability. So institutionalization should be stopped and abandonment not accepted. And then ensuring all the supports necessary during quarantine of persons with disability. Measure of public restriction must consider persons with disabilities on an equal basis with others, and persons with disabilities in need of health service because of COVID shouldn't be deprioritized on the ground of their disability, which unfortunately is something that has been happening. Organization of persons with disability can and also should play a key role in raising awareness and also in advocating for the inclusion of disability in the response. So most of the resources about the MHPSS response adaptation to COVID, but also the inclusion of persons with disability in the COVID response is available in the toolkit, MHPSS COVID-19 toolkit at the MHPSS.net website. But we are now working to provide guidance on the intersection of these two aspects, and therefore to have an MHPSS response inclusive of persons with disability in all the emergency settings, including pandemic. So I hope we will be able to share this short and operational tool very soon. I think I talked too much. I expect, unfortunately, we are not in the same room, so I cannot see if after lunch you are sleeping or, or so bored. And I think we could now share a little bit of practical experience. I know that the organization Polish Humanitarian Action has been implementing an impressive program and project. So if they would like to share it with this group, it would be such a learning opportunity. And if there will be some time left, I can also share the experience of Italy, especially the sub-region where I'm working. So if the Polish Humanitarian Action would like to share their work, I'm really keen to hear.
Colleagues from Polish Humanitarian Action, over to you.
I will be brief. A brief description of our activity and our project, as I've already mentioned. Our project deals with psychosocial support of elderly at the demarcation line, and at this pandemic there were a lot of transformation and adaptation efforts. In the framework of our project, we not only run the individual support, social support, but as well social, purely social support, like we provide some assisting devices, some food sets. But I would like to concentrate on psychological support, and the program we adapted because of the pandemic situation, COVID-19. First of all, elderly people living at this demarcation line, they are socially unadapted, they are not supported in a social sense, they suffer from living alone. Our program, loneliness, our program contains training in social routine skills, self-advocacy, capacity building in sense of emotional state, increasing social relations in local communities. Because of the pandemic situation, in the framework of our program, we included 2 sessions with facts and figures about COVID-19, preventive and treatment methods, behavior in COVID-19 situation. Because in fact, the elderly people, in many cases, they have disinformation, they have true information, fake information. In many cases, they just listen to their neighbors and their relatives. So that's very important to have these eye-opening sessions with them, speaking of these problems. The program contains the information on how to recognize stress, how to cope with your emotional situation, emotional state. the format of our trainings and lessons or sessions was simplified. We even tried to run our trainings or education, so to say, by phone. And you understand that that the program should be simplified, of course, not only for the trainer, but for elderly recipient as well. Each and every session is 30 minutes long, because it is very difficult for anybody to perceive more than 30 minutes or to concentrate on more than 30 minutes. And then it will not be an adequate perception of information. We ran once a week the meetings or telephone meetings, so to say, with each and every person. Each and every session ends up with small homework. We recommend older people to do this homework till the next session. There is clarification for trainers for each and every task. Probably some advices on hands-free loudspeaker, switching on the telephone, etc. So we tried to simplify those tasks, exercises, maximum level for anybody to easily conceive this information, to understand the information, and for them the tasks not to be very difficult. So we developed even special methodological directions or manuals, if you please. So anybody could be self-supportive, could understand the exercise and could perform those exercises. Speaking of the difficulties and achievements in our program, the major difficulty was the remote format of that sessions. This is absolutely new experience for all of us. And in order to be successful in implementation, we had to have very um, plain language to be exercised here. Another difficulty, and Anita already mentioned that, difficulties in communication. For elderly people, the smartphone or telephone, it's rather difficult to understand how to work with that. So sometimes we had our communication difficulties. In the beginning of this program, there were certain difficulties in developing a rapport with us, because they were very suspicious. Probably you're burglars, or probably you're involved in certain scam or something else. So they didn't understand the benefit from our communication. So in online, in telephone format, it is much more difficult to come to this type of report, this type of trust, which is different from personal communication when you see the eyes. But finally, we managed to do that, to manage to establish a rapport between our expert and elderly people. So they liked our intervention, because they started to understand that somebody takes care about them, and it is very important for them that somebody takes care about them. Somebody is interested in his or her psychological state, etc. As well, we'd like to mention that after we told them normal figures about COVID-19, the level of anxiety was lowered with that people, because they understood that now they are protected and they knew how to deal with the first symptoms of COVID, where to go and whom to approach. It is very important to give certain instructions, very simple advices, for elderly people, where to go, how it could be manifested some symptoms, because in real life many people they been lost in these symptoms, in thoughts, where to go, what to do, etc. And finally, 72% of our beneficiaries, their psycho-emotional state has improved. They are looking optimistic with into the future. They are interested in other people. They learned how to relax, how to feel them more relaxed, more demanded, and they understood how to support themselves, how to help themselves emotionally as well. In our project as well, we had elderly disabled people. They were even the immobilized people. So online format for them was not good, was not accessible actually. So we ran individual case management, means that our people with all the proper protective measures, protective gadgets worn, they came to the apartments of such people and they support them, because it was for them dangerous to be left alone with their problems, with their thoughts. Moreover, they need additional support and additional attention, so additional care. So we have difficulties, but we have our own achievements. Yes, of course, it is a new format for us in sense of psychosocial support, but we have positive results, and in the future we'd like that we have eye to eye rather than distanced communication. Starting from July, in 4 of our locations, we started to come physically. If that could be done in the open air, then we did it with all the proper protective measures, with a restricted number of participants. And it was great because people, they were missing each other, and we wanted to finally look into the people's eyes. That was our experience of adaptation. So if anybody has any comments or interventions, I am all yours. Thank you.
This is like just a comment. It's really impressive, the work that you have been doing, especially targeting such a difficult population, meaning the elderly facing so many heightened and multiple risks. So I think it's really, I mean, it should be a shared learning experience. And I was wondering, how did you enrolled the persons? Like, how did you contact them and propose them? Well, because we did something not so well and not so comprehensive in my region. But for example, we got the anaggraphic from the public health department, and then we called all persons in the region which were 65 years old and over. And it was like the recruitment was very difficult. So I would like to ask you if you can spend some more words on the recruitment, initial recruitment part, and the need assessment, if you had the chance to do it. Because, for example, we assumed some of their needs because we had no means for the assessment, but then, I mean, as always, the programs which are not informed by a needs assessment are always partially effective. So I was curious to learn from you. How did you recruit the elders, and if you were able to conduct also a preliminary needs assessment?
Thank you for your question. Now, project, our experts, our workers, the social workers working for, say, governmental facilities, and they, of course, have all the necessary data in this specific place or that specific town or that specific settlement. So there were no problem for us because we had all the data in hand. We even had our all the necessary data if this person, elderly person, is disabled or probably he needs some medical aid. That's why it was very easy for us to work with that category of our people. Moreover, as I mentioned already, we had group and individual sessions. So this individual case management was applied to people who were unable to participate in a group sessions because they had limitations in movements, etc. Then we ran individual sessions for them. If we are speaking about the assessment, we used WHO methodology before and after our sessions. We were able to measure.
Reacting, Alisa, to what you were saying, it's definitely much more challenging to develop an inclusive MHPSS response of persons with disabilities when the system is so institutionalized, like so based on institutionalizations at all levels, like social level, the health care levels. It's really like very challenging, and it's not going to happen in, you know, like overnight. And I strongly believe, having worked for so long in countries with a very, let's say, institutions centered system, I believe that substantial changes requires time, and they have to, let's say, to be, in order to be long-lasting changes, they need to be respectful and require time, because it involves so many different aspects. It's not only about a reorganization, of course, of the services, but it's about a policy level, let's say, mentality. It's about the culture. So it requires a lot of complementary efforts. At the same time, I strongly believe that emergency can cater these reform processes. We have been seeing it all over the world and documented it, but sometimes like reality is not fully reflected in documents. But I could experience that the emergency can really be like the opening of this opportunity because of reorganization, but and also because some funds may be available for the MHPSS sector, which is not always the case in, let's say, regular times. Although it's about a lot about shifting resources from institution to community-based, but we all know that this transition requires also extra budget. It's not enough to shift resources and capacities and so on. So I mean, if we want to look at the, let's say, light light side of the coin, we say in Italy. So maybe this COVID could help like strengthening the reform process at the national level, although it's so challenging, and while it happens, persons with disabilities unfortunately pay the price of not being included.
But good news that our Building Back Better in Ukraine has started, and the National Mental Health Concept Note was adopted by the government a couple of years ago, and it's really oriented on building community-based mental health system. So it's just to finalize on a positive note, and yeah, probably COVID can how to say,
attract more
yeah,
attention.
more attention to further development of the mental health system. Yeah, thanks.
Amazing.
Colleagues, any other comments, questions? So over to you all.
I would like to add a couple of words about our own work, how Coolpage works in sense of psychosocial support of elderly people, and how we work with disabled people. Speaking of the questions from Anastasia, I would like to mention that before we as an international organization start working with elderly and start in any location, first of all, we start with a focus group. That's a must for us, where we invite people with different types of disabilities or problems. Could be impaired listening, or bad eyesight, or disoriented, or dementia, Alzheimer, etc. As well, we took into account the gender parity, not only men or women only. So in that focus group, we start with the questions of the following nature. What barriers do they have? What obstacles do they have in their life? What they'd like to change? What types of actions they'd like to participate in? Speaking of our own actions, our own sessions. And only then we start to build up a plan for half year, for 1 year, how to work. We develop as well as schedule or scale, how to work with the people, elderly people and people with disabilities. We start with kind of a questionnaire here. I show it to you. The questionnaire devoted to vulnerability. And we work not only with people with disabilities, but all types of elderly people, taking into account everything. Do they have access to drinking water, to medical services? To what extent he could move and come to our center personally? So what I'd like to show you, that we have a special manual, and in this manual, it is specifically devoted, specifically aimed at people with impaired hearing or impaired eyesight. He or she could point out, for instance, he'd like to have help from medical nurse, so he put his finger into that pictogram and then put his finger into yes sign. So it is very simple for them, so we take it into account working with our volunteers. As well, we have a working group uh, dealing with with the elderly disabled people. We developed 8 major advices for our volunteers, how to work with people. That 8 advices, for instance, eyesight problems, move closer or give him hand for him to touch and feel that I am a living object, I am warm. So, or If anybody has impaired listening, we have our special manual. So as for the COVID surrounding, yes, we changed many things. We have two directions in the help page international. We have two types of volunteers, immobilized and movable, so to say, beneficiaries. As well, we have a special center for communal leisure. So by means of pension funds and the departments of social protection, we disseminate announcements that there is starting work in our social center. So we invite volunteers to participate. So in last half year, we attracted 250 beneficiaries. Among them, we have people that is temporarily disabled, IDPs, internally displacement persons, and we have some plans. We changed our activity, we changed our programs because of COVID-19, so we concentrated on remote activities at home. For instance, knitting, checkmates. We bought sets for checkmates, and we are speaking about small movements, small motoric actions for these people with dementia. For these people to be able to do something and to show to their grandchildren, etc. But everything has changed now because of the quarantine restrictions at present time. They have from us the coronavirus brochures, recommendations how they should behave, what they should do. And the last I would like to mention here, as for the barriers and the obstacles, what did we see? We must work with local authorities in any locations, because many people with disabilities, they became abandoned, and basic services are closed for them, medical aid, pharmacies, anything, and humanitarian. And this is the major points where volunteers help them to get access to these basic services, because our local authorities not necessarily has ability to have high quality information services or high level of high quality service in any humanitarian sense. For instance, some disabled persons, his certificate of disability has expired and he doesn't know what to do next. We approach our Department of Social Protection for them to give us understanding what is the procedure for reconfirming the disability of these, for instance, disabled people, and attention given and attention paid to these quarantine obstacles, how to call for therapist to come to his home. That's what Help Age International deals with in Ukraine. If any questions, I'm ready to answer.
This is really innovative approach, and even many approaches, and you are very creative. So thanks a lot for this great work. And just one very small remark, since you see I'm from WHO, I just must say that please be careful with shaking hands. So that's only one small remark. That's it. But generally, really great work, and probably over to you, Anita.
Yes, really impressive. And I was really amazed in seeing, like the establishment since the beginning of the consultation process with persons with disabilities through the technique of the focus group discussion, in order to involve them since the very beginning in the decision-making process, in the planning process, through then the implementation. For us, this is like the first key action. If you remember in the presentation that I shared with you, like first key action is the consultation with the organization of persons with disabilities and with persons with disabilities in order to, you know, like assess their needs and to co-design the program since the first step. So it really amazed me hearing that it's happening actually.
Thank you very much.
Alex, so we running a bit over time, and probably you have some last comments, questions to Anita. So you are welcome now to introduce them. If not, then I have one from my side at least, very last question to Anita. So Anita, can you please give us as a group advice, very practical advice, something that we hardly can find in all guidelines, and we have a range of them now. So what would you advise for us, for partners, for each MHPSS partner or partner who work in this area, at least partially? So what we can, coming back to our work today or tomorrow, what we can easily and simply do and to improve our work and in this direction towards people with disabilities and vulnerable groups, something very practical if possible, something very simple. Thanks.
I mean, I could say a lot of things, but like to start, just establish a coordination mechanism, like just identify organization or self-advocates, like directly persons with disabilities representing disability diversity, and start a consultation process with them, which means like a meeting or a focus group, and like collect from them inputs about the barriers they are facing to access MHPSS support. So then once you have like heard from them directly, you can start like with the adapting and retrofitting your programs. Like each organization has its own MHPSS program or component and so on, starting from very basic things like universal design, which means physical accessibility of facilities, like there are stairs, so remove the stairs or put a ramp, like the doors are wide enough for people to enter, like physical accessibility, but also signage, like you have a pictorial indication to move, like for the mobility within the facility, and reasonable accommodation. So like the twin track approach, which is universal design, like make your activities accessible to everybody, and then the reasonable accommodation, identify that person with that specific disability, what does it need to participate to your program. So it could be like the sign interpreter, it could be like you need to translate, for example, a key resource, I don't know, the first psychological aid or whatever resource you are using in your program in Braille, for example, or in multiple format. These are very, like, let's say, simple and practical things that you can start tomorrow doing, like having in mind the multiple languages and format for communication, and accessibility of your activities, which is physical accessibility and also materials provided in different format. And then when you think also the capacity building activities, you do training, you do session, like think that people with disabilities must be included. So what can you do for that? providing easy to read version of the materials, providing signal interpreter again. It's a lot about physical accessibility and communication, a lot. But first of all, let's say, as a consultation with them, to hear from them what they need and what are the most common barriers they are facing. So these very practical tips from tomorrow.
Thanks a lot, Anita. Thanks. It's really valuable and really implementable tomorrow. Yeah, that's true. Thank you very much. Colleagues, so taking that we have almost 15 minutes over, we unfortunately have to finish our workshop, and with this I would like to thank Anita. It was really great and very important for Ukraine in terms of our development context and humanitarian context, and taking humanitarian crisis that we have had before COVID, and also COVID brings new challenges. So we have many now materials to digest, to think, to rethink. Thank you very much for your support and for your time. Probably if colleagues, if you have any questions related to the workshop, you can reach out us with Oksana, and we can we can follow up with Anita. So thank you again to all, and Anita, thank you again, and
thank you very much. Presentation was absolutely great, very clear. It was super.
Thanks a lot, Elena, for your very positive feedback and engagement and great work you are doing, and to other colleagues as well. And so with this, unfortunately, we should stop. We wish you all the good rest of the week and good evening. So let's be in touch as usually.
Thank you so much to everybody. It was really a precious experience for me, and a learning experience, hearing from you. And the last thing, don't forget people in institution. Remember always them.
Yeah.
Thank you so much.
Thank you. Thank you very much, Anita. Colleagues, so bye for now.
Bye-bye.
Goodbye.